Comprehensive Approach for Treating Fractured Central Incisors by Bacus, Jemarie Belnas, Eila Marie Bulaclac, Shannen Dhana Canales, Ashley Joy Maglinte, Mariz Angela. Introduction.
A fracture at or below the gingival margin poses challenges for rehabilitation, affecting both aesthetics and fracture management, leading to heightened sensitivity and discomfort. Prompt intervention, like applying a crown or dental implant, is crucial for restoring functionality and appearance, preventing progressive damage and long-term complications. Thus, dental professionals must thoroughly examine and treat such fractures to ensure optimal oral health. This proactive approach prevents infection spread, preserves tooth integrity, and helps patients avoid complications like tooth loss or extensive future treatments, ultimately enhancing their quality of life and oral health.
Chief complaint.
A 13-year-old male patient reported to the dental office with the complaint of dislodged prosthetic crowns in the upper front teeth region. Anamnesis revealed a history of root canal treatment and full crown restorations in the maxillary anterior teeth. Clinical examination revealed dislodged metal ceramic crowns on 11 and 21, with the fractured tooth structure lodged within the crowns, Fig. 1. The average probing pocket depth was 2.5 mm and the width of the attached gingiva was 3 mm. Radiographic examination disclosed a suboptimal obturation of the root canals of both 11 and 21, Fig. 2. Fracture of the teeth was seen to be at the level of the alveolar bone crest. Root length was assessed to be adequate to achieve 1:1 crown-root ratio following orthodontic extrusion. The course of treatment requires an interdisciplinary approach. Orthodontists, endodontists, and general dentists are involved in the treatment process of cervically fractured central incisors. Determine the extent of the fracture. Endodontic treatment is the initial step. Perform a root canal to save the tooth. Orthodontic appliances are required for extrusion and labial movement. The next step is to do a periodontal examination to address any issues with the supporting structures around the teeth. The final stage of treatment is restorative procedures, which involve restoring the tooth's function and aesthetics. Long-term monitoring is being done to ensure that the treatment is successful. Also, patient education is important.
Collaboration. In the management of cervically fractured central incisors, employing a multidisciplinary approach, endodontics, orthodontics, periodontics, and restorative dentistry collaborate seamlessly. Diagnosis and evaluation. An extensive clinical examination is required to determine the extent of the tooth fractures, as well as the state of the pulp, root, and surrounding tissues. Endodontic treatment. Addressing the pulp and root canal concerns, ensuring the structural integrity of the tooth. Orthodontic treatment. For extrusion and labial movement, an orthodontic appliance is required to align the maxillary arch. Periodontal treatment. Periodontal procedures like crown lengthening with osteotomy and gingivectomy, as well as treating the surrounding bone of the teeth. Restorative and prosthodontics. Restorative dentistry collaborates with prosthodontics to determine the type of treatment and prosthesis that will be installed to assure the teeth's aesthetics and function. This cooperation between several dentists guarantees that the patient will receive superior care that provides both function and aesthetics. Procedures and techniques. Non-surgical endodontic retreatment was done in 11 and 21, and both teeth were obturated by lateral condensation, Fig. 3. Post spaces were then prepared to a depth of 11 mm and size 3 piso reamer, Mani Inc. Japan. J-hooks fabricated in 19-gauge stainless steel wire, Sendon Inc., Tennessee, India, were luted within the prepared post spaces of both teeth. The patient was referred to the Department of Orthodontics for extrusion and labial movement of 11 and 21. 0.022. Slot with MBT prescription, 3M Unitech, Monrovia, USA, were placed in the upper arch, Fig. 4. After initial alignment and leveling, an L-hook was placed with 19x25, SS, incisally, and an active ligature tie was given to the J-hook, which was then activated at 3-week intervals, Fig. 5. Orthodontic appliance was in place for 14 weeks by when the adequate height had been achieved, and the orthodontic appliance was debonded. At this stage, the probing pocket depth was 3 mm, and the width of attached gingiva was 4 mm. Crown lengthening with osteotomy and gingivectomy was planned. This would expose an additional 1 mm of tooth structure for obtaining a ferrule and also help aesthetic correction of the gingival levels. The attachment of the labial frenum was noted to be high on the ridge, which was also planned for simultaneous correction in conjunction with the crown lengthening. Fig. 6. Following healing, cast posts were fabricated on 11 and 21. Fig. 7. Heat cure acrylic temporary crowns were given after tooth preparation till the passive eruption was complete. After 6 months, metal ceramic crowns were luted on 11 and 21. Fig. 8, 10. After initial alignment and leveling, an L hook was placed with 19x25 SS incisally, and an active ligature tie was given to the J hook, which was then activated at 3-week intervals. Fig. 5. Orthodontic appliance was in place for 14 weeks, by when the adequate height had been achieved, and the orthodontic appliance was debonded. At this stage, the probing pocket depth was 3 mm, and the width of attached gingiva was 4 mm. Crown lengthening with osteotomy and gingivectomy was planned. This would expose an additional 1 mm of tooth structure for obtaining a ferrule and also help aesthetic correction of the gingival levels. The attachment of the labial frenum was noted to be high on the ridge, which was also planned for simultaneous correction in conjunction with the crown lengthening. Following healing, cast posts were fabricated on 11 and 21. Fig. 6. Heat cure acrylic temporary crowns were given after tooth preparation till the passive eruption was complete. After 6 months, metal ceramic crowns were luted on 11 and 21. Fig. 7. The excellent results and outcomes of a recent multidisciplinary case involving the management of complex dental fractures. This treatment not only addressed the immediate concerns, but also laid the foundation for long-term success. Clinical improvements. Crown placement. As you can see in Figure 8, porcelain fused to metal crowns were successfully luted on teeth 11 and 21, restoring their form and function. Post-operative view. Figure 9 showcases the final post-operative appearance, highlighting the natural aesthetics achieved. 6-month radiograph. Figure 10 demonstrates the stable position and healthy bone surrounding the restored teeth at the 6-month follow-up. Patient satisfaction. The patient has expressed sincere satisfaction with the treatment, appreciating the following aspects. Tooth preservation, avoiding extraction and maintaining natural teeth was a major priority, and that objective was achieved. Improved aesthetics. Regaining a natural appearance boosted the patient's confidence and overall well-being. Enhanced function. Chewing and speaking are now comfortable and effortless, significantly improving the patient's quality of life. Positive treatment. Response. The patient adapted well to the prescribed treatment plan, making the process smooth and successful. Increased confidence. The restored smile and functionality have positively impacted the patient's confidence and self-esteem. Improved quality of life. Daily activities and enjoyment are now enhanced thanks to the successful treatment outcome. Long-term success. The meticulous planning and execution of the multidisciplinary approach minimized the risk of future complications. Additionally, the use of cast posts and a proper ferrule provided extra strength and stability to the restored teeth, promoting long-term success. Additional improvements. It's also important to note that the successful root canal retreatment contributed to pain management and improved overall oral health. Discussion. The implications for future interdisciplinary dental care emphasize the vital need for a holistic strategy in managing fractured front teeth resulting from dental trauma. Acknowledging the immediate pain and patient stress, dentists must prioritize careful planning, taking into account potential complications to optimize treatment outcomes. The demonstrated collaborative model involving endodontics, orthodontics, periodontics, and restorative dentistry establishes a valuable precedent. This interdisciplinary approach not only ensures a comprehensive understanding of the complexities, but also tailors solutions to address various aspects of the patient's oral health. Encouraging such collaborations moving forward is essential, fostering continuous communication and knowledge sharing among dental specialists to refine and advance treatment strategies for traumatic dental injuries. This patient-centered, interdisciplinary paradigm holds significant potential to improve the efficiency and efficacy of future dental care, especially in challenging cases of dental traumas. In conclusion, this case study demonstrates the crucial role of a holistic, interdisciplinary approach in managing complex dental trauma involving fractured front teeth. By prioritizing careful planning, considering potential complications, and collaborating across specialties, dentists can achieve optimal treatment outcomes for their patients. Fostering communication and knowledge sharing among dental specialists is essential to refine and advance treatment strategies for traumatic dental injuries.